a little bit of those in sort of an overview fashion so that EMS providers and agencies will have an opportunity to train in-house on each of the protocols and the changes to those protocols that are coming out. So if you don't mind, let's go over that just a little bit.
Absolutely. One thing that I'll add, Melissa, just so providers in the field kind of know where we're at the PIMS Council, we revise protocols once a year now. We have our policy and protocol committee that meets, that's made up of peers, providers from agencies from the top of the Northern Neck all the way down through the peninsula. They meet once a month. They discuss things they want to see changed. They build these protocols. Then it goes to the Medical Advisory Committee, which is made up of all the OMDs from the region. They either give their approval, they make their changes, they do that type thing, and then it comes back to us at the PIM staff. One of the staff members, we then start getting it all set up and getting in the protocol, and then we do a protocol rollout. So we're now doing a protocol rollout once a year. We're still working off of that protocol manual that we made, you guys did in 2012. And just every year we're making revisions to that as see fit, and we'll either alter a protocol as science changes, or we'll introduce a new protocol, or if something is no longer needed, we'll remove it. So that's kind of the working document, but that's kind of the process of how we develop new protocols.
Great, and I understand with the 2015 protocol revision, there have been 3 of the current policies that are being removed.
That is correct, Melissa, and that's one thing that we want folks to really take note of. When they get their packet of things that they need to change for the 2015 revision, it'll always have a date for when that protocol was made. And that's the protocol that you put in. You remove those old pages, you put those new pages in. This year, there's been something different. We've removed 3 things in the protocol manual that are no longer needed. So they'll see on that form that they get that it just clearly says remove. There's nothing to replace that with. It just says remove. One is the medication exchange policy, medication box exchange, because it's a brand new policy. We didn't want to put something in the protocol for 2015 and then halfway through the year we noticed that we need to adjust something. So we asked folks to refer to our website to keep up with where we're at with the new protocol correction with the new medication box, but they won't see anything in the protocol manual about that. Nor will they see anything about exemption for testing, because we now know that testing exemption is no longer needed. So we've removed that one, as well as physician signature. As we've just talked about, that's no longer needed for protocols that are done within standing protocol. And that's kind of been a changing thing as well, as everybody kind of gets their feet wet and understanding that regulation change. So again, we ask folks to refer to the PIMS website for information on that, and they won't see that in the manual this year either.
Okay, so if an agency has additional protocols, maybe they carry a medication that their operational medical director is allowing them to experiment with, and they have their own internal SOPs dictating that,
right,
that would still require a signature by the hospital?
Well, what would have to happen is their doctor would have to sign off on it, and a copy of that protocol would have to be in the emergency room as well in the pharmacy, so that the pharmacist can verify, if need be, yes, this was done within standing protocol. They can still do it without signature if it's their department protocol. But they would need to make sure that that policy is both in the pharmacy and the emergency room. A perfect example of that, a lot of agencies are now doing rapid sequence intubation. There's several in the peninsula who are doing that. They just need to make sure that a copy of that protocol is that their physician has signed off on, their OMD, is in the pharmacy and in the emergency room.
Great, that's very good. Now, can we cover some of these new
Absolutely.
changes that are located in the protocol book? Some of them will jump between the pharmacy section as well as the actual adult protocols, and there are a couple that are located in the procedures section that is
Right.
commonly referred to. And the first one specifically being the Narcan. There's some new changes on the way, especially as it relates to the EMT providers within the PEMS region. Can you tell us what's changing?
Right. Melissa, in the ultra-level consciousness protocol, for suspected overdose, we refer folks to give Narcan as an antidote. As you know, there's been a huge rise in the Commonwealth and across the country in narcotic overdose and death. And there's been a lot of aggressive approach for the lay person to be able to give Narcan, as well as law enforcement officers. And so we really wanted to kind of get behind that movement empower our BLS providers, our EMTs, to be able to give Narcan. Unfortunately, an EMT can't do med math by the scope of practice for Office of EMS. So one thing that we found that we can do is they can give Narcan by nebulized. They can give a nebulized Narcan just like they would normally give a breathing treatment, but now we're going to give Narcan. And what they'll do, or naloxone as commonly referred to within the box, they will give 2 milligrams, which is one of the pre-fills that's in the medication box. They'll put that into their chamber, just like they would for if they were going to give a normal breathing treatment, and a 3 ml sterile saline bullet, as they're commonly referred to. Normally they're pink, I believe, and they will pour that in as well. So the Narcan goes in, and then the saline goes in, and then that's inhaled, and they'll titrate it to effect. And what we mean by titrate, typically what we're concerned with folks who have taken an overdose is their breathing. Their respiratory rate is really low, and we want to increase that respiratory rate. And so what they'll do is they'll put that mask on them. Even though they're breathing slow, they're going to inhale that medication. As their respiratory rate increases back to a sustainable number to sustain normal life activity, we would ask that they take that nebulizer off and they can hang it up. Don't spill that medication. If their patient again starts to, the respiratory rate starts to decrease and they need to give more medication, they can put that mask right back on them. And we call that titrating to effect. We do that as ALS providers with the amount of medication we give. This is just how they're controlling the amount of medication they're giving as the BLS provider.
So 2 points I would like to make sure we clarify for those that are within the region. They're going to use the pre-filled box of Narcan, sort of a salmon colored box.
Correct.
So they will take that out, set it up, and actually squirt that into the little cup that they'll use to administer the medicine. Then they're going to take a pre-filled, what some people refer to as a bullet of inhalation saline.
Yes.
Now that doesn't get confused with saline in the bottle or a saline flush or IV saline. They're different products.
Different thing.
Because it contains the products to keep it safe for inhalation.
Right, absolutely. So they can't just use something different. It has to be one of those inhalation bullets.
Prepared for respiratory care. And so they'll put those 2 items in the cup and secure the cup, and they can place it on the non-rebreather mask, and then they'll let the patient inhale it. They can also use a nasal airway in place if they need to maintain an airway. Is that correct?
That is correct. Just following their BLS airway procedures. We're just kind of giving them another tool by adding the Narcan to it. But you're exactly right. And one thing that we really recommend, Melissa, is that agencies do training on this. This is a new skill for the BLS provider. We recommend that on one of their training days or training nights or whenever they're getting together to do training, this is one of the things they really go over.
Good. It's probably a really good idea. And they would also then have to cover how the provider could potentially access the medication box if they don't have access, if they're using a lock and key or if they have a punch code system, and who has the authority to take care of that.
You're exactly right. So they'll need to know the new medication box as well.
The new procedures. One of the other protocols that has some minor revisions to it is the stroke or CVA protocol. Can you talk to us a little bit about that?
Absolutely. Melissa, we have really become aggressive over the last year with our stroke task force, our STEMI task force, as well as our trauma task force. Those are task forces that meet within the region. They're made up of folks from their field of expertise. For example, with the stroke, we have neurologists that consult with us, the stroke coordinators for hospitals, as well as pre-hospital providers, as well as helicopter EMS folks who all get together and work on these protocols. And one thing that's really exciting is that we've increased our time that we would call a stroke alert or an active stroke. Used to, we said 0 to 2 hours. With the new protocol, you'll now note that it goes 0 to 3 hours. And that way, it moves it out another hour that we're calling the stroke alert. And then also, we're empowering the provider to that if you're between 3 hours and 12 hours, call the stroke center and consult with them and see if they want you to maybe transfer them to a stroke center or just go to the local hospital. But we wanted to give providers a little more aggressiveness when we're talking about strokes. We know strokes have really become a hot topic for us in EMS, and we know we're doing really great things with strokes now and saving a lot of lives. So we wanted to become a little more aggressive with that as well.
Very well, very well. And I noticed too that you've made a few changes actually for the stroke checklist that's contained. And this is a list that the EMS providers or their agencies can actually maybe put in a PDF file and put on their computers, or keep paper copies if they're still using paper type forms, so that the provider will have some standard questions that they'll want to go ahead and make sure that they complete before they arrive at the hospital or shortly after arrival. And it says to leave a copy of this with the emergency department where the patient is delivered to. And I noticed that there are some minor changes to this form this year.
Absolutely. Before we called that our thrombolytic checklist, Melissa, and it had a lot of information on it. It was really good information. But again, when this task force came together, the hospital staff said, well, it was hard for us to extract the information we needed quickly. The providers were telling us, matter of fact, yourself, that there was a lot of things that was taking a lot of time to fill out, you know, in the heat of the battle, as you would. So we tried to make it very simple. Hospitals have now said, stroke coordinators have now said, this is such beneficial information that they're going to require their staff to ask for this from EMS providers. We have, hopefully, we're going to get some funding to print these, at least for the first round, and get them out on the pre-hospital trucks. But again, it has a lot of good information. It talks about things like last time seen normal. We know that's really important to know the last time a person was seen normal, because that is a huge factor in that 0 to 3 hour range, or that 3 hour to 12 hour range, depending on what type procedure, a lot of times very invasive procedure that the neurologists are going to do. So it's important information. We wanted to make sure we captured that person's name, who's seen them last, their phone number, and then we've put a lot of good associating information like blood glucose, big key items that may rule them in or rule them out for some invasive procedures. So I really encourage folks to take a look at that, and most importantly, we encourage providers to start using that. Hopefully that's going to really speed up things at the hospital, as we can move them along that care process a lot quicker.
Great, very well. So providers should take a look at this, and agencies should probably train their providers on the expectations about completing the form, and then of course leaving it at the receiving facility.
Absolutely. And a couple, if I can add one more thing or two more things to that, Melissa. With the stroke checklist and the stroke protocol, we're now using the FAST exam acronym. Before we had the Cincinnati Stroke Scale, the FAST acronym. We've now just went to the FAST, the facial droop, the arm, and the speech, and time. And the reason we did that was because that's what is being taught to the public as well. So we wanted to be consistent with that, so we went to FAST. The other thing I'll add to stroke that you'll see in the stroke field triage is that we've added 2 new stroke centers in the last year. We're really excited about that. Riverside Doctors of Williamsburg has become an accredited stroke center, as well as Rappahannock General Hospital in Lancaster County. So those are 2 more stroke centers, and there's an entire list of all the stroke centers within the PIMS region on that field triage.
Great, very well. And the next procedure page that has some changes to it this time is the ventricular assist device, also known as the VAD page. Tell us a little bit about that.
Right. You know, Melissa, that was in our protocol from 2012, and over the last 2 years, we've seen a lot of VAD patients move into the region and or visit here for vacation. VADs are becoming much more portable. So you're seeing a lot of people travel with them now, and they're really being placed in a lot of patients. That's a left ventricular assist device. The things that we changed this year, and we encourage people to really review this protocol, and maybe even do a training class on this as well. But the things that have changed are, now we're really recommending you do a chemical code. If you have a patient who goes into cardiac arrest with the VAD, we're recommending you do all those drug therapy that you normally do in a cardiac arrest, and then we recommend that you contact the VAD coordinator for the place where that VAD was placed to see if they want you to do CPR. There are some hospitals that say don't do CPR on our VAD patients. Some hospitals say yes, do CPR on our VAD patients. So what we want you to do is contact that hospital early on, even if you can do it while you're en route to the call. One other benefit that we added was the phone number for the VAD coordinators for Bon Secours, Centera, and Virginia VCU in Richmond. Those are the 3 we're really seeing a lot of patients come from that have VADs placed. So we're recommending that folks call those VAD coordinators early on as you find out where they had their VAD from.
Very well. So that'll be a pretty significant change